So we see the case vignette. A 25-year-old woman presents to emergency room for a fever. What's the problem in this sentence? The fever is going on for last 2 months. She complains of shortness of breath, some malaise, and arthralgias. Possibility. What does she have? There is too much fever. There is shortness of breath. There is malaise. There is some arthralgias. Yes. SLE could be a diagnosis. Very good. Why do you say infective endocarditis? Arthralgias. So the differentials, chronic fever with shortness of breath, could be pulmonary tuberculosis, but there are usually no joint pains in tuberculosis. Tuberculosis is a disease which generally the patients, they tolerate well. For example, if you see a patient who has got tuberculosis and another patient who's got some other reason for chronic fever, the patients with tuberculosis, they generally tolerate the fever and symptoms well, not very complainant that we have got body pains are painful and the disease is difficult to tolerate. Generally, they tolerate it well. And then you can have autoimmune diseases. They can present with fever and joint symptoms in young patients. Malaise can be a feature. Infective endocarditis, also a possibility. Chronic empyema. Empyema produces shortness of breath in a normal person. If you've got normal lungs, empyema generally does not produce shortness of breath until it's massive. So now we see physicals. She is mildly anemic, has splenomegaly. Joints are painful, but they're not swollen. A pan-systolic murmur is audible at the apex. What is your first diagnosis now? Is infective endocarditis. What is your second diagnosis? What would you consider as a second diagnosis? Yes? Huh? Rheumatic heart disease. Starting in at the age of 28 years, rheumatic fever generally starts in younger patients. It can start till the age of 40, but it's generally a disease of younger patients. Joints are swollen, migratory arthritis. Fever doesn't last that long. The fever that lasts that long, rheumatic fever, generally settle down early. A second diagnosis is infective endocarditis. I have put infective endocarditis so much emphasis on. Why? This is a very serious disease. You're tired? This is a very serious disease, and delay in diagnosis, delay in treatment have these consequences. And then it can be connective tissue disorders. Now the labs of the patient, the hemoglobin is on the lower side. ESR is 65 millimeter in the first hour. So inflammatory disease is going on. Ultrasound, there is mild splenomegaly. Chest X-ray is mild cardiomegaly. Now, this is the key investigation. Slightly dilated LV with an LA with mild MS, severe MR, and soft tissue mass attached to the posterior leaf flat. So the patient has mixed mitral valve disease. Mixed mitral valve disease generally means post-traumatic fever. Otherwise, if you see congenital mitral stenosis is an isolated disease, mitral regurgitation of non-rheumatic origin is not associated with MS. So if you've got on mitral valve, which is both components, stenosis as well as regurgitation, this is usually post-traumatic. So this soft tissue mass, this is now key. to diagnosis. This is patient with infective endocarditis. Now, what is infective endocarditis? What is infective endocarditis? A self-explanatory term. Infection of the endocardium. It can be bacterial, viral, fungal, fewer other microorganisms. Can the infective endocarditis be without infection, this endocarditis? Can it be without SLE? What is that called? Lemon sac. So it can be without infection as well. Now, how do you make the diagnosis of infective endocarditis? How do you diagnose it? Yes? Yeah. Yes. Yes, this is the Duke's criteria. Now, what are the Duke's criteria? Yes? We not go for pathology. We are clinicians. So if there are two major criteria present, if there is one major and three minor criteria present, and if five minor criteria are present, this is infective endocarditis. So you require two major criteria, one major criteria plus three minor criteria, or five minor criteria. Now we see what are these major and minor criteria. Now the major criteria is two positive blood cultures and echocardiographic evidence. Now what is the echocardiographic evidence? Presence of vegetation, presence of abscess, dehiscence of a valve, or there is new onset regurgitation. These are echocardiographic criteria which favor the. It's not only valve stenosis. If these are present, these are echocardiographic criteria, two positive blood cultures. Now we got minor criteria. If the predisposing factors are present, for example, if the patient has valvular lesion, there is chronic fever, embolic signs, one positive blood culture, complex immunological phenomena. What are these embolic signs? If the patient has stroke, spots are complex immunologic phenomena, glomerulonephritis, arthritis, positive RA factor, or Roth spots. So these are complex immunological phenomena. These are not embolic phenomena. Embolism is, for example, if you've got an absent pulse in the foot, if you got stroke, or you got, for example, infarction in the gut or eye, the patient becomes blind, retinal artery occludes. So these are embolic phenomena. So you've got complex immunological phenomena. This is glomerulonephritis. Then you've got serological confirmation of infection. In some patients may be required. Echocardiographic signs do not meet the major criteria. I told you the major criteria. There's vegetation, there's abscess, dehiscence of the valve, or there is onset regurgitation. If these are present, these are major criteria. So if the echo has an evidence but does not fulfill the major criteria, this will be minor criteria. Now, what are the risk factors? Residual valve injury, rheumatic fever most often, pacemaker interventions, congenital heart diseases, IV drug users, immunosuppression for whatever reason, diabetes, steroids, drugs, advancing age, and prosthetic valves. So these are the risk factors on which endocarditis can develop. Now, what lesions in the heart are more prone to develop endocarditis? For example, in a patient who got pure MS and another patient who got pure MR, who is more at risk of developing endocarditis? Yes? MR. MS and ASD, atrial septal defect, are low risk lesions. So whenever there is a very high pressure gradient of solution, that lesion is more susceptible to endocarditis. For example, yes, AR, MR, VSD, PDA, they have high pressure gradient across the defect. So they are more vulnerable for infective endocarditis as compared to ASD, which is a low pressure shunt. MS, what the difference between LA and LV across MS? It's pretty small. When you compare with MR, MR means when there is systole, the blood pressure is going to go to 120. Pressure is few millimeters only. So this is a high gradient. Even in diastole, the LV pressure is pressure in LV at the end diastole 80 millimeters. Am I correct? Yes. How much pressure in the LV? This is the ends. 80. 120, is the pressure of aorta, not LV. LV pressure is 120 over 0. When the systole finishes, it opens, there is a pressure drop sudden. So this pressure, 120/80 is the pressure in aorta, not in the LV. Now it's about 1 in 100,000 in US population. We don't have statistics. Typically affects adults. Males are more prone. Children may present with without evidence of valve disease, and location is mitral valve more than aortic valve, than tricuspid valve and pulmonic valve. These valves are generally involved in intravenous drug users. So right-sided valves are generally involved in drug users, while the left-sided are involved for systemic needs. Acute endocarditis, streptococcus, if IV drug users or they are very large agitations, 1 centimeter or more than 1 centimeter, this is likely to be staphylococcal disease. Neisseria, subacute endocarditis, streptococcus gloiticus. Now, if you get this thing on culture, should have a colonoscopy. This has a strong association with colonic cancer. If a patient with endocarditis you find on culture streptococcus, go for a surveillance of the colon. This is associated with colonic cancer. Then you can have enterococcus if the procedures are done on GI tract or genitourinary system. Streptococcus viridans after dental procedures, upper respiratory tract infections, staph epidermidis, prosthetic valves, and candida in IV drug users. So these are the usual organisms which involve the patients with endocarditis. Now, what's the clinical presentation of patients who present with endocarditis? As we discussed, the patient may have persistent fever. Fever may be low grade to high grade, intermittent, particularly in staphylococcus. You may have high swinging temperature, and if a patient has chronic fever, low grade fever going on, and the patient has developed suddenly high grade fever, think of an abscess formation. That abscess may have developed. There may be shortness of breath. Patient may have systemic symptoms like weakness, fatigue, malaise, myalgias and arthralgias, headache. So these symptoms may be present in patients who present with infective endocarditis. Physical examination, as I mentioned, precordium is very important. There may be murmur. New onset changing murmur is very important. So changing murmur would be a stenotic murmur or it will be a regurgitant murmur. Most of the time it will be a regurgitant murmur. Peripheral signs, patient may have anemia, there may be splenic enlargement, there may be embolic phenomena, patient may have Roth spots, retinal hemorrhages on fundoscopy, Janeway lesions are macular lesions on the palms and soles, they are not tender, and you can have splinter hemorrhages, immune complex deposition, maybe producing oscillon nodes which are seen as tender nodules on fingers or toes. Well, out of these, well, I have seen a few Janeway lesions and these retinal hemorrhages. Really, I don't have seen many of these oscillor nodes. But if they are present, they are very suggestive that the patient has infective endocarditis. endocarditis. Splinter hemorrhages are not a very hard sign of infective endocarditis. They may be seen in trauma, or they may be seen in patients who got SLE or other things. So the osseous nodes and Janeway lesions are given particular weight. Blood culture. There's a particular method of taking blood cultures. It should be taken from different sites within half an hour and be sent for examination. Prior antibiotics can reduce the yield of culture. Echographic predictors of embolism. What predicts that these vegetations are going to embolize? What vegetations and echo can tell that these vegetations embolize? What are those factors which tell us they can embolize? For example, if the vegetations are multiple, they are greater than 1 centimeter, they are pedunculated, they are non-calcified, and they are prolapsing. So these vegetation can break off and go into the systemic circulation, cause ischemia and something. Culture negative endocarditis is seen in 5 to 12% of cases. These are fastidious organisms. Prior antibiotics can reduce it. What are these fastidious organisms? Gee, this is really actually. Yeah. So what are these fastidious organisms? These organisms which are difficult to growth. So these are called fastidious organisms. For example, anaerobic organisms, fungus. ECG may reveal conduction delays or heart blocks, particularly if the aortic root is involved. So there you got, when there is the aortic root, the major bundle passes through that, and if it's involved, you may have these conduction delays or heart blocks. Complete blood count, ESR, pretty non-specific. Ultrasound may show splenic enlargement, organ abscess formation if there is embolic phenomena into the liver or spleen. Urine analysis may show hematuria, proteinuria. Now, what's the treatment of infective endocarditis? Keep in mind, when you suspect 2 diseases, it should not be delayed. Treatment is very, very general. One is infective endocarditis, the other one is the cardiovascular system. Treatment must not be delayed. What's that condition? Yes. So meningitis is another infective condition where treatment, you cannot afford to delay treatment, has consequences because there is a continuous death of neurons, and if you delay the treatment, the patient will have neuronal damage that may not be obvious immediately, but it has consequences. So these two conditions, if you've not given antibiotics within half an hour, you have done very much harm to the patient. So you should be quick in assessment. IV antibiotics as early as possible. Immediately, if you consider that this is infective endocarditis, take samples for blood culture, give antibiotics. Empirically, vancomycin and gentamicin for a total of 4 to 6 weeks. You can change antibiotic according to response and culture results. Appropriate therapy for conditions like heart failure, and you see amphotericin B and 5-fluorocytosine for fungal endocarditis. If you are suspecting fungal endocarditis, for example, if the patient is a drug user or patient is immunocompromised, you can start these drugs. Then in some patients, you may require surgical assistance. Where you require surgical assistance? If the patient has fungal endocarditis, it's very difficult, very resistant type of infection which does not respond very well. So you may require surgical intervention and surgical clearance. Heart failure does not need medical treatment. Persistent sepsis, this may be because of abscess formation, and you may have to drain the abscess. Conduction disturbances by aortic root involvement, recurrent septic emboli. Facing infection between aortic and mitral valves, which causes the adherence of these valves and intractable heart failure, may require surgical assistance. Now, what are the differential diagnoses of infective endocarditis? So these are atrial connective tissue disorders. This is also a connective tissue disorder, is it? Intra-abdominal infections like liver abscess, Lyme disease. What is Lyme disease? Yes. Borrelial infection presents with chronic fever, joint pains, neurological involvement, and maybe cardiac involvement. Polymyalgia rheumatica, reactive arthritis, these are variable differentials of this condition. Now, an important thing, endocarditis prophylaxis. Who should be given endocarditis prophylaxis? Yes? IV drug users? Yes?
Dental procedures.
Which patient? So if you suppose, if I get a dental procedure, I require endocarditis. Prosthetic cardiac valve, including transcatheter aortic valve replacement (TAVR). So if the patient has prosthetic cardiac valves, should be given prophylaxis if the patient has a dental procedure, if the patient has to undergo endoscopy or there is intervention in the urinary tract, these patients should be given endocarditis prophylaxis. The second category is prosthetic material used for valve repair, for example, annulus we have placed or the cords, they should be given. Cardiac transplant with valve regurgitation due to structurally abnormal valves, these should be given endocarditis prophylaxis. The fourth category is congenital heart disease. So you got prosthetic valve, prosthetic material use, cardiac transplant with valve regurgitation. So in these patients, endocarditis prophylaxis, and the fourth category is patients who got congenital heart disease. All congenital heart disease prophylaxis. Blanket category is any type of cyanotic congenital heart disease require antibiotic prophylaxis for infective endocarditis. Then any congenital heart disease repaired with prosthetic material surgically or percutaneously up to 6 months after the procedure or lifelong if there is a residual shunt or valvular regurgitation. So all cyanotic diseases, patients who got prosthetic material placed in, give prophylaxis for 6 months, and if there is a residual shunt or leakage, it should be for life. Repaired congenital heart disease with residual defects at the site or to the site of prosthetic. So all these patients should give endocarditis prophylaxis. Now, what endocarditis should be given? What is the drug which you use? Ampicillin, standard drug, 2 gram of ampicillin. If the patient cannot take orally, it should be given parenterally, ampicillin, cefazolin, or ceftriaxone. Patients who are allergic to penicillin, you can use cephalexin. Cephalexin should not be used, or second or third generation, or even first generation cephalosporins should not be used in patients who got immediate type of hypersensitivity reaction to penicillin, for example, urticaria, angioma, or anaphylaxis. If patients are allergic to penicillin and then show angioedema or anaphylaxis, or if they show this urticaria, in those cephalosporin should azithromycin or clarithromycin can be used, or even in older patients, doxycycline can be used. So these are the different antibiotics which should be used for prophylaxis. The most important is amoxicillin. So you give standard 2 grams of amoxicillin. Otherwise, you can use alternative like azithromycin, clarithromycin, and doxycycline. Now, follow-up of this patient. The patient was put on antibiotics, vancomycin and gentamicin. Now she landed weeks after that with severe abdominal pain and vomiting. What's happened? She was going all right. She started having abdominal pain and vomiting. She was vancomycin, gentamicin. What might have happened? Is it causing? And the nephrotoxicity be causing pain? Why there will be pain in nephrotoxicity? Won't be any pain. There will be just decline in kidney function. So the patient has developed a complication. Examination revealed absent bowel sounds. Now what is this? Yes? Mesenteric ischemia, good. So the patient has embolized in the mesenteric system. So there is mesenteric ischemia and there is intestinal obstruction because of the ischemia. So this will require surgical intervention. So the complications include pericarditis, myocardial infarction, valvular insufficiency, congestive heart failure, myocardial abscess, conduction block, sinus of Valsalva aneurysm. Patient may have arthritis. Arthralgia are usually present with chronic endocarditis. What is this arthritis? What sort of arthritis they can develop? They can develop arthritis because of the immune-mediated phenomena. They can develop septic arthritis. What goes and settles in the knee joint. You can have a septic arthritis. Then you got arterial emboli, stroke, ischemic limb, gut, kidney, eye. So the embolus can go to any place. Maybe in anterior spinal artery aneurysm, the patient has paraplegia. So it can go into any artery. And then patient may develop glomerulonephritis. So these are the various complications of infective endocarditis.